Welcome back from the break. I'm excited to be moderating this panel on building from first-in-class treatments and the future of the amyloid hypothesis. This was a milestone year for the treatment of Alzheimer's. The first disease-modifying drug therapy was approved in the US under the accelerated approval pathway, and it is being reviewed in additional markets. Biogen put out a statement this morning indicating that they had been advised that there was a negative trend at the November meeting of the European Regulatory Agency, but that a final decision was not going to be made until the meeting of the CHMP in Europe, which is December 13 to 16. Other disease-modifying drugs are under regulatory review or well on their way, from Lilly and Roche and Eisai. So with this first-in-class treatment, we're poised to learn from new real-world evidence and to benefit from the same incremental progress that we saw in other disease areas like oncology and HIV/AIDS. You all remember that we also have an approved drug in China from Green Valley called the Green Memory drug, which in fact is only approved for marketing in China. The Aduhelm drug is approved for marketing in the United States. Other jurisdictions will make different decisions. I am reminded that in fact, Aricept was first approved in the United States and only much later was it approved in the UK. So we will be in a state of evolution here in this area in the coming months and years. And so we're going to be dealing with what are the big questions once we begin to get more drugs on market in the coming year or 2 years. What do we need to do to make sure that we're ready as a people, as patients, to get access to those drugs? What do we have to do with our healthcare systems? What do we actually communicate to payers and health technology assessment authorities as the value of therapies? How do we educate practitioners? How do we motivate consumers to recognize that there may be therapies on market? And how do we introduce new technologies that are lower cost and more accessible to be able to test to see whether we have the disease that's appropriate for the drugs that are going to come on market? I'm joined by an esteemed group of panelists to help tackle these questions. I'm going to ask each of them to introduce themselves, like with one question, starting maybe with Howard Fillett.
Oh, thanks, George. And it's great to be here with everyone to discuss this important issue. I'm Howard Fillett. I'm a co-founder and chief science officer for the Alzheimer's Drug Discovery Foundation.
Ivana?
Hi, thank you, George. My name is Ivana Rubino. I am the Vice President for US and Global Medical Affairs at Biogen, working on Alzheimer's.
Jeff.
Yes, Jeff Cummings. Thank you, George. Good to be here in Lausanne. We will look forward to a great discussion. I'm director of the Chambers-Grundy Center for Transformative Neuroscience at the University of Nevada.
You seem to be the only person here actually in Lausanne. Jeff, you didn't get the message, huh? And Nikki, oh no, you're in Lausanne too, Nikki. Good. Nikki, just a word of introduction.
Hello, my name's Nikki Bayliss. I'm head of development with Alzheimer's Disease International. We are the global federation of 105 Alzheimer and dementia associations worldwide.
Great. Ivana, first to you. From your perspective, how do we move from a sort of a non-existent drug world to a world in which we have multiple drugs on market? What can we learn from oncology and accelerate those learnings into the Alzheimer's space?
Thanks, George. First and foremost, going from a drug-free to a drug-rich world is the best thing that can happen to a field. And while the road is a little bit bumpy, it's not always easy. I think we will all look back at these days in the near future thinking about how historical the moment was for all of us. Recently, besides oncology and HIV that maybe for some are so different than neurology, we have seen this happening in areas like SMA. We went from a lethal disease, path of disease, no options for patients, to a place where, while the disease, of course, it's still a life-threatening disease, patients finally have options. And what we have observed is that there is a very fast change in the way how physicians talk about the disease, how patients go through the diagnosis, and all the treatment expectations have really dramatically changed. I always say that patients and families went from hoping to have some extra days of life to now dream of doing things like running the Boston Marathon. And this is a bit of a paradox, but just to say, as we move into this drug-rich world for Alzheimer's disease, we will have to rethink how do we diagnose the patients, how do we establish treatment expectation, and how do we monitor for that? We all know that in our clinical trial Reach Life, we have learned about some of the tools that may actually enable us to assess and evaluate benefit risk of drugs under experimental setting, but we should all agree that these tools won't be sufficient for a real world monitoring of treatment effects. And that's where we need to come together as a community to reestablish what do we do, how do we follow up our patients on a daily basis, and how do we really tailor the benefit and the outcome that we hope to obtain based on the patients we have in front of us versus the clinical trial population. And I think real world data in that sense will be a critical tool for us to really understand more and more, especially if we are really entering this drug-rich world. We will have more options, and therefore, how do we identify the right patients for the right drug? So all of this will be very interesting topics that I'm sure as a community we will tackle.
Nikki, same question from you, for you, but from the perspective of patient organizations. What is the role? What is our role? I put myself in the category of a patient organization. What is our role as we move from a drug poor to a drug-rich environment?
Yeah, I mean, I think we have to recognise that Alzheimer and dementia associations play an incredibly important role and need support, particularly with sharing information as the landscape changes. Certainly with our World Alzheimer report this year, which focused on the journey to diagnosis, we found that 55% of people who received a diagnosis said that they didn't get, adequate information at the point of diagnosis. And what we're seeing is that, Alzheimer and dementia associations are really filling the gap. But people are having to find associations by themselves. Clinicians are not routinely signposting people to the associations, which actually have a wealth of information. And I think as the landscape changes and more therapies come on stream, we should anticipate that many more phone calls will come through to association helplines. And we really do need to help them to be able to field those questions, by providing the right information, support and training. This is quite complex information that they need to be able to digest and decipher. And we need to be able to help them to do that.
I'm sorry, Jeffrey, you have a comment?
Oh, yeah, I wanted to bring up one more example. You were asking about examples like from cancer. I'd like to just introduce the model that multiple sclerosis provides, because this is so fascinating to me. 1983, beta-seron was brought to the FDA, and it received an accelerated approval based on the MRI findings. Very controversial at the time. That was followed by 15 disease-modifying drugs in multiple sclerosis. So it opened the floodgates by making an advance that people could have confidence in. And of course, it had to transform all of multiple sclerosis care. And it took time. I think that's a transitional process that we are in now.
Jeffrey, do you recall sort of the major steps along that pathway? What was it that you say you now have 15 drugs as opposed to zero? What caused clinicians to understand how to use those products in clinical practice? What were the major step functions that caused the change?
Well, I wish I knew the answer to that, George. We're going to have to go back and map it out. One thing I would say is there's been a lot of concern about, well, does Aduhelm make it more difficult to develop other new drugs because the trials are more complicated? And you can see that we have so much to learn from MS because they went from nothing to 15 drugs. So there have to be models in there, and we need to learn from them. I don't know them right now.
So Howard, this notion that we're going to go from a single experimental drug to a single approved drug, and then to potentially in the next year or so, 2 or 3, potentially 4 drugs. how are we going to really understand the real world benefit of these products?
Yeah, I think that's a critically important question, George. What's the real world benefit of drugs like Aduhelm? And since we haven't had any drugs, we haven't been able to do the typical long-term modeling studies to look at what are the long-term benefits. And I've had the good fortune to be involved with some folks at Biogen recently, Peter Pemberton Ross in particular, and some others, Chris Leibman, to look at the real world benefit of Aduhelm using a Markov modeling approach, which I won't go into. It's kind of complicated, but basically we took the data from eMERGE and modeled what the long-term benefit would be. And this is a standard approach in health technology assessment because you have these clinical trials of 12 to 18 months, but maybe what we really want to know is what the impact of 12 to 18 months of treatment is on long-term survival, on risk for institutionalization, and on risk of moving from, let's say, MCI to moderate dementia, which is a big jump in terms of quality of life. And in fact, what is the impact of the drug on quality of life using these modeling techniques that are really classic health economic techniques and techniques that are also used by payers to look at the value of drugs, which is something you mentioned earlier, George. And what the study, which has been published, showed was that the lifetime probability of using Aduhelm in the eMERGE study, lifetime probability of transitioning to AD dementia was reduced considerably by about 1.5 to 2.5 years compared with current standard of care. There was an increased median survival in the MCI AD group at about a year, and there was a decreased risk of hospitalization during this time and increased median survival time in the community. So these are not only quality of life, there was also an improvement in qualities over the long term in this model. So these are relevant health economic outcomes of the drug that will be considered by, especially in Europe, where health economic outcomes are very important to approval, whereas in the United States, the FDA doesn't consider health economic outcomes, but payers do. And you mentioned the wide variety of decision-making among healthcare systems and payers in the U.S. as far as the use of the drug. And I think this kind of health economic approach to modeling and showing the long-term benefit can have an important impact on the way payers in the U.S. and approval agencies actually in Europe will look at the long-term data. And I want to say that what's really exciting, as Jeff mentioned, to this is that there are over 100 drugs in development right now for Alzheimer's. And for the first time, 75% of those drugs are non-amyloid drugs. They're drugs that attack things like inflammation in the brain and epigenetic drugs and drugs that are looking at metabolic disturbances and autophagy and so on. So we have many different kinds of drugs. And if you want to make a comparison, I would go back to where we were 50 years in cancer, where we were throwing toxins at people and creating all kinds of combinations of 3, 4, 5 drugs. And that's what we're going to need in Alzheimer's disease. So this really is the beginning. We have a drug that seems effective, and we have follow-on drugs that sort of increase the overall confidence in this approach. But this approach of anti-amyloid, there's no doubt in my mind, is going to be in combination with other drugs that attack other pathways in the biology of aging that are affecting the aging brain and creating risk for Alzheimer's disease. So I think, the last thing I want to say is, and I think we've alluded to this, but we haven't emphasized this, is that what's really enabled this modern era, which I believe it is the entry into the modern era of Alzheimer's therapy, are the biomarkers. The PET scan for amyloid, which drove the accelerated approval of Aduhelm. We now have a tau PET scan on the market, which is going to revolutionize not just trials, but also clinical care. And the blood biomarkers. I mean, we have a blood test on the market for Alzheimer's disease. That's incredible. And it's been enabled by technology because we have the sensitivity now in these assays to detect minute femtomolar amounts of blood analytes like tau. And there's so many other biomarkers in development now. We have a blood test for amyloid. We're going to have a blood test in the next year or two for plasma tau, which is going to be even better than the blood plasma and have a different role in clinical care and in research because, the tau biomarker might be more correlative with cognition and be a better surrogate marker than the amyloid, which is characteristic and necessary for the diagnosis of Alzheimer's disease. And those biomarkers are going to drive clinical trials and they're going to change clinical care, going to make it much less expensive, and it's going to be a revolution. So I'm really excited about what's going on now. It's amazing.
And George,
go ahead, Ivana.
I think, last week was really the breakthrough week for blood biomarker. Many of us have been discussing what if one day we have blood biomarkers, right? And last week we saw data coming from different molecules. Of course, you all know I work for Biogen. I'm very proud of the 7,000 sample data we presented on November 11. And we start seeing that we can actually see downstream effect that stem from the removal of amyloid. So all of a sudden, all the things we have discussed before about the framework of this complex disease start being supported by data, and especially the blood biomarker open up a new future for us because the RUN report a couple of years ago showed us the biggest issue we have in Alzheimer's disease is the delay in diagnosis. People don't want to talk about that. Doctors may not have immediately the right tools to do that. Now we are at that point. We're talking about Alzheimer's has become a part of our daily jargon. I am from Sicily, and this summer I can tell you everybody was asking me about Alzheimer's. Everybody was asking me when to get worried about Alzheimer's, which is an interesting fact. But now not only we are talking about Alzheimer's, but we will soon hopefully have tools to diagnose it timely, not just if you live nearby a center of excellence. So whoever is saying that innovation is not happening, maybe is not following closely the news, because we are really living the revolution of Alzheimer's disease, and that's fantastic.
George, can I comment on one?
We had a very informative panel on blood biomarkers yesterday or the day before. All these days are running together. And the challenges of getting them approved, paid for, and implemented at scale are daunting. So that the revolution, you could see it, but it isn't here yet because we need to actually deploy these innovations in blood biomarkers and potential digital assessments at scale. So they're scientifically getting validated, but we need to deploy them. Jeffrey, I interrupted you, please.
No, I interrupted you, George. Thanks. I just wanted to comment on something that Howard said that I think is so important, because there's been concern is, yes, there are changes, but are they clinically meaningful changes? And I think Howard has one of the answers, because what he said was you would spend one more year in the mild stage of Alzheimer's disease. Howard, did I understand that correctly?
A year and a half.
Year and a half.
Year of survival, year and a half of delayed progression to moderate AD.
Exactly right. This is grandma being able to enjoy her grandchildren, to enjoy her life, to enjoy her husband for a 1.5 more years before she develops dementia. That's just so fantastic, and that kind of impact on people's lives just has not been emphasized enough.
And I
Nikki,
think
how did we get this message? Your ADI report showed that 2/3 of the world doesn't believe that this is a disease, but simply a natural course of aging. The doctors really do not think they can do anything. And here we're hearing about this revolution that is emerging, coming. It's on the verge. How do we get that message through to the world's clinicians and indeed to the world's patients?
Yes, I think you're absolutely right. The statistics that came through from our 2019 World Alzheimer's report really showed, that stigma is prevalent, whichever region of the world you live in. 62% of healthcare professionals, like you say, still believe that dementia is a normal part of aging. 35% of carers globally said that they'd hidden a diagnosis of dementia. So there's a huge amount of stigma that we have to overcome, to prepare the way for this revolution that will take place. I think it is really, down to all of us to increase awareness, to continue to increase awareness. And I think for us, we've been really pleased to see how much momentum has built with our World Alzheimer's Month campaign over recent years. We were delighted that 45 million people were touched by our communications this year, which is fantastic. But we still need, to explain, how things are changing. And I think personal testimonies can be a really critical part of that. A few years ago, we ran a series of webinars about the importance of participating in clinical trials. And as part of that, we invited someone to share their experience of participating in a clinical trial. And I think, those personal testimonies are really powerful, in explaining, how these therapies are working, and how things can change.
So go ahead, Ivana, please.
Sorry, I want to go back because when I think about oncology, when I grew up in Sicily, we never say the word the cancer. We say people were dying of a bad disease. Now, years later, we talk about cancer. And that's really because there is something you can do and people can embrace the diagnosis. It creates empathy around the patient. We need to do the same process for Alzheimer's disease. Today, the word does not spell out. Nobody wants to be, diagnosed with Alzheimer's because it's a life, like there is it's a death sentence. We need to make sure people understand, in this edge of the progress and the revolution that's happening. Alzheimer's should become a disease. As you go into the doctor, people should ask you, how is your heart? How is your brain? And from there, having all these options for the patient. That's, I think, what maybe we will witness in the next 10 years.
If I
I see this revolution. I'm sorry, go ahead, Howard.
Yeah, I mean, I've
been talkative panel.
George, when I went to medical school, Alzheimer's disease was not in my textbooks. Okay, literally not in my textbooks. When I trained and saw hundreds and hundreds of patients as an intern and resident, old people, I never made the diagnosis of Alzheimer's disease. I never heard of it. This is the mid-'70s. We've come such a long way from when Alzheimer's was recognized by Bob Butler in his book, Aging in America, which won a Pulitzer Prize in 1975, predicting and acknowledging for the first time the coming epidemic of Alzheimer's disease. That wasn't that long ago. And I remember when donepezil came on market, Pfizer did a tremendous effort at educating people about Alzheimer's disease. The VA did it. And so we've come to a day where I think most doctors and most people in the US at least have heard of Alzheimer's and they are afraid of it. But the problem in really translating the recognition, I believe, is not so much the stigma, but the lack of therapy. And because what changed tremendously the landscape of Alzheimer's was the approval of Aricept, the approval of donepezil. It made something available that we could tell people, if you get diagnosed, you can take this drug. And yes, it's not a cure, but we're on the right road. And now we're finally on the road of disease-modifying therapy. So, in my professional lifetime, I've seen unbelievable changes going from literally nothing. When I used to tell people what I did, I used to say I do research and I take care of people with Alzheimer's disease, and they'd look at me cross-eyed and say, old-timers disease? I never heard of old-timers disease, and now it's on everybody's list. So I think I think the landscape has changed enormously. We've made incredible progress worldwide. And with the advent of Aduhelm and I'm sure the other antibodies, and then other kinds of therapies, I think we're rapidly going to go from a very nihilistic view about the disease to one where there's a lot of hope for realistic expectations of the impact of therapy.
So Howard, you're a clinician. You actually see patients in the clinic, and you're sitting there with a patient who is a very early stage of the disease, MCI or early AD, and you now say there is a treatment. Let's talk through how this might benefit you. By the way, if this benefits you and we can manage the side effects, but you're not going to get better. You're only going to decline more slowly. Yeah. So, we have seen this when my cholesterol numbers go down, we celebrate that because I've got a number that shows that, some state of my body has improved over what it was. How do you explain the benefits of a drug, even though they can't see that the fact that they're getting better? What is my Alzheimer's number or my beta amyloid number that says, gee, my beta amyloid's down? This is good news.
Yeah, I mean, I think having the biomarkers is helpful, but I think the kind of long-term benefits that the modeling study illustrated are really clinically meaningful. They're real-world benefits. It's a real-world study. Being able to tell people, as Jeff said, and as I mentioned, that there's a delay of a year and a half to moderate dementia, a delay to institutionalization, a reduction in the number of people that get institutionalized ultimately, and even a survival benefit. I think these are the kind of long-term outcomes that people can really, latch on to, because, we're talking about people at age 75 that have a life expectancy of maybe 7 or 8 years. And adding on, if they have a functional life expectancy of, let's say, 3 or 4 or 5 years, right? Because when I say functional life expectancy, I mean, the ability to do things in their daily lives independently. Functional life expectancy, even in the early stages of the disease, is quite limited. So adding a year or two of functional life expectancy on someone that has 3, 4, 5 years of functional life expectancy is a very big percentage gain. And when you see, what cancer therapies are really adding to life expectancy, literally life expectancy on the nightly news, we see all this glory and everything, but the fact is that we're not adding that much time to life expectancy with cancer drugs, yet people value that. And I think in the elderly, this adding on a year or two, as Jeff said, of being able to communicate with your grandchildren is very clinically meaningful. So we don't have, the cholesterol, we're still prescribing on faith because the numbers needed to treat is so large. 150 people, doctor has to treat 150 people for 5 years with a statin to prevent one heart attack. But we don't do it that way. We just think of it in terms of the biomarker. I think this is even more meaningful than the biomarker. It's what the biomarker means.
So, Jeffrey, I'm curious as to the decision-making on the part of some very prominent health systems, Mass General, Mount Sinai, Cleveland Clinic, who are not going to carry this drug in their formulary. But obviously, the doctors within those systems are still able to prescribe the drug, but have to use an outside infusion center. What's driving those decisions?
Really great question, George. And with regard to Cleveland Clinic, although I was a staff member at Cleveland Clinic, I do not know the actual decision process for that decision. And I think there are two aspects of it that I would predict. One is the absence of certainty about coverage right now. So I think the expense of the drug, whether healthcare systems would be reimbursed, I think that's a critical issue because healthcare systems are not working on that large of a margin to ensure their economic success. So that's a very important part of it. And the other is the exact question that Howard has been highlighting here, which is clinical meaningfulness. The slowing in the EMERGE trial was 22% overall on the overall analysis. If you looked at the patients who were treated with the 10 milligrams per kilogram, the highest dose for at least 14 months, that slowing was 30%. Well, some people are going to argue, is 22% enough? Is 30% enough? For me, and that's why Howard's analysis is so great, because you get it into a different time frame. You say, okay, I have another year of cognition. That's just so important for people. So I think another reason that boards are hesitant is there must be an internal dialogue about, is it enough? And then the other is payment.
So, Ivana, how is Biogen thinking through the gathering of the evidence needed to demonstrate this Markov model of a year and a half of extended functionality at the early AD stage?
So, of course, as Howard explained, that's a model base using all the data we have. But of course, prospectively, what we are doing, and George, you may be aware, we started our first real-world phase 4 study called ICARE-AD. The idea is the trials up to phase 3 are limited in time. You go up to 18 months and then you assume what may happen later. But the truth is that we want to see those data in the real world. We want to see those data in patients that are representative of the population. As you know, we are also ourselves giving a goal of ensuring that underrepresented population are part of this effort so that we cross correct for what historically we have done in Alzheimer's disease, but also that we can follow up patients for a longer period of time. What happens, especially as people continue treatment, what happens as the comorbidities may worsen, how does it really impact the outcome of Aduhelm on patients' health? But when we speak about clinical meaningfulness, I think we need to go back to one of the best projects we have done with you, George, which is the What Matter Most study with Deborah and the team. Because when we think about those scales that we use in clinical trials, those are really aimed to look at a population response to a drug. But as we go into the real world, each patient, and that as we learn from that work, each patient may have a different goal. We heard some patients have the goal to continue reading the New York Times. That's really what they deem as high quality of life. Other patients may want to be able to drive and keep babysitting their grandchildren. How do we ensure that in our decision-making process in whether or not someone is benefiting from a drug, how do we incorporate the personal part of it? Alzheimer's is such a personal disease. In the study, as Jeff, briefly mentioned, we look at the data population-wise with the validated scales. In the real world, we will start gathering and learn more about what matters for patients such that the benefit-risk profile assessment becomes almost a personal one, a decision between the physician and the patient. And that's what I hope in the years to come, we will keep learning. And of course, knowing what's happening on the underlying pathology level through all the biomarker will also give us a sense of how this correlates and will inform also decisions on how long to keep patients on therapies. I believe this is one of the largest gaps when you start introducing drugs in the real world for a new disease. And only the data from real world will enable us to have appropriate decision-making also about around duration of treatment.
Nikki, I am curious, since you represent essentially the whole world, how relevant it is that we have a disease-modifying therapy that's been approved in the United States, and all this excitement around the possibility of a clinical product, clinical conversations, and new technologies in the way of blood biomarkers and digital assessments. Is that relevant to the rest of the world? And how do you project to the rest of the world that in fact this is coming and we ought to be paying more attention to it, either as clinicians or as consumers?
Yeah, I mean, I think it's very relevant to the rest of the world. I think we're at a time where, the global community has been waiting for decades to see change happen, and at last, now it is, and certainly when we heard about the FDA approval in the US, we had questions and comments from our member associations around the world, really welcoming the news and, having that hope that treatments will be accessible for them. We were asked by so many people, when will aducanumab be available in our country? And I think we've been reaching out to our members to ask them, what are your hopes for these new therapies and what concerns do you have, if any? And we're getting a really positive response, that I think these new therapies are broadly welcomed, across the world. I think, there is a concern about cost, and reimbursement, and the fact that, the resources and the capacity to diagnose is missing, the expertise to prescribe is missing, so there are many, many things that we need to work on. But I think one of the most positive things that has come through is actually that, members are learning from the US and seeing, all of the issues that have arisen around, reimbursement for Aduhelm and access to Aduhelm. And actually some are already writing to their ministries of health to ask for meetings, to say, these new therapies are on the way and our health systems are not ready, and we really need to talk about this and work out a way, to make sure that the people in our country living with dementia will have access to these therapies as they come on stream.
George, can I comment on that?
Yeah, go ahead, Jeffrey.
I just want to say one thing about it, because I think what Nikki is saying is so important. We want equity to Alzheimer's disease drugs. We want people, wherever they are in the world, to have access to them. And this class of drugs is very difficult to make that happen. But for me, the importance is this represents proof of concept. We have we have shown that we can modify disease. We have shown that we have biomarkers that can demonstrate the biological impact. We've shown that there's an FDA pathway for approval. And for me, it's actually, more convenient drugs, more drugs with fewer hurdles to administration, that those are the drugs we're looking for and that we must achieve equity with.
We're going to hear later this morning, from Janet Woodcock, who talks about the value of the accelerated approval mechanism, why it was used here, how it's been used in oncology and in HIV, so that you will see a perspective from the FDA about their motives for how they acted and why they acted, which was to stimulate innovation. So we're going to have sort of in the next steps category, we're going to have payer decisions in the next few months. After that, we're going to get more clinician engagement, hopefully, in prescribing the medicine. We're going to get more consumer engagement in terms of asking about their brain health or their brain condition, making routine a checkup from the neck up as a checkup from the neck down, so that we can begin to get at this. But if you look through those things, it is payers, it is health system readiness, and it's clinician and consumer readiness to take this on. Those are steps that sound logical in sequence, but they're each going to take a fair bit of time. Jeffrey, you wrote a very good piece with others regarding the sort of the protocols that clinicians should look to decide whether to prescribe the drug. You might just briefly describe that. What your motive was, what kind of uptake you've had on that piece.
Yes, thank you, George. What happened was, as you know, there was some controversy about Aduhelm as it was going to the FDA. So we were really watching this decision very closely. June 7th, they approved the drug. We were able to see what the prescribing instructions looked like. And we realized that there was quite a lot of difference between the prescribing instructions, what had happened in the trial, and what clinicians were going to face in the clinic, and that we needed to take those prescribing instructions and translate them into clinical care. And so that's what we did. We assembled a group of experts who were very knowledgeable about this. Paul Azen, the head of the ACTC, and Mike Weiner, the head of the ADNI, other people who are very knowledgeable about the science of Alzheimer's disease and also treatment, like Steve Salloway, for example. And we put these together in a very detailed way. We had great support from the editor of JPAD. This was Bruno Velas. And Bruno also realized that this had to happen and it had to happen fast. So he really worked with us to get fast peer review, let us advance the quality of that article, and we got it out within 5 weeks of the approval of the drug, which is, I think, put it in the hands of people at the time that they needed it, because you need to know how often are you get an MRI, what are the symptoms that should trigger an off-schedule MRI, what is a dose escalation, what is the best type of memory care once Aduhelm is available. These are the questions that we tried to frame and to provide preliminary answers to in the appropriate use recommendations. I'm proud to say it's been downloaded 14,000 times so far, and it's only about 3 months old at this point. So it is a document that people are turning to, and I'm very, very proud of our group for doing that.
Ivana, we talked about actually gathering the evidence of clinical benefit here. You have at least two studies underway. One is the possibility of the confirmatory trial, the so-called phase 4. I'm curious as to what the status of that is or the planning for that is. And the other is iCare AD. How do those two distinct processes work? What is their timing? When do you expect some sort of readout?
Actually, there are 3 because you also have EMBARK. So maybe I can start from EMBARK because as you all know, when futility was declared, all the patients who were actively involved in the aducanumab program got discontinued. And then with all the work that happened bringing aducanumab back, we actually started what at the time we called the redosing study, offering the opportunity for patients to come back on drug. Now, because I'm an optimistic, I define EMBARK as the only silver lining of the futility analysis situation because it gave us an opportunity to see what happens to patients during a drug gap period. You may have seen a sheet that we presented the baseline data, which speaks about what happens when patients discontinue drug and restart drug. Specifically, we saw that the amyloid level remains stable, while patients keep progressing, even if at a different speed compared to the ones who were on placebo. Speaking about the fact that maybe there is much more that happens in the brain when we treat with a drug like aducanumab, and how do we best decide when to discontinue treatment in order to really tackle the disease progression. We don't want our patients to just be controlled by the amyloid level and thereafter continue progressing. So that speaks really about what we need to do as a community. Now, specifically for the PMR and ICARE-AD, these two studies are very different. ICARE-AD is a single-arm study, real-world study. All the work we did to develop the protocol was really thinking about how do we measure the domains of the disease with tools that can be used in real world. And also in the selection of the clinical trial sites, we went beyond the list of clinical trial professionals. We went across the setting of care because we want to really see how applicable and how real world use of the drug may vary depending on which kind of setting of care you're receiving the drug and being managed as a patient in. So ICARE-AD, because of being a single-arm study, will allow us to give continuous data. We can read out multiple times, and it will keep giving us information. The PMR is a little bit different because it is a placebo-controlled study. That's part of our regulatory requirement. I don't have a lot of updates for you today. The only thing I can say is that the team is working really day and night in order to finalize the protocol. The protocol will have to satisfy not only regulatory requirements, but also other stakeholder requirements. And it's most likely going to be a global study. So you can imagine how that protocol may need to satisfy multiple levels of requirements. One thing I want to make sure this group takes away is that that study is really critical. So at Biogen, there is a dedicated group of people who are really trying to think how to expedite all the side of study initiation and study, completion without, of course, jeopardizing quality. So I can tell you right now, my thoughts are with my colleagues who are really thinking about, in a world that is moving from drug-free to drug-rich, how do we do a large randomized control, placebo-controlled study? And that's, I think, going back to what Jeff was saying, the MS example will become critical for all of us. We at Biogen have been very involved in multiple sclerosis, and we have learned how you can do studies while drugs are available. But still, there is a lot we will keep learning, and I hope I will be able with the team to come back and share with you what we learn.
So, Ivana, go ahead, Jeffrey.
Sure. Sorry to interrupt.
No, please.
One of the additional sources of information that may be important is the Alzheimer's Association is starting a registry to follow patients on all of the new treatments, as well as patients who are off. So we'll learn more about that in the next few months, I'm sure, but that may be even another source of information beyond those that Ivana described. The other thing I want to bring up is there were very few minority patients included in the Aduhelm trial. I think it was less than 15% of the entire population. And I think, Ivana, is this correct that iCare will have a large representation of minority patients so that we can begin to understand whether there are differences in safety or efficacy across these different populations?
Yes, we give ourselves a goal as minimum. 16% of our patients will be underrepresented community patients. But I want to underscore it's just the minimum. It doesn't mean that, we will try to gather more and more data because part of our focus has been, it's not just about recruiting the patients in the trials. It's how do we ensure that they go through a patient journey that is appropriate? What are the barriers this patient face? We have actually, especially in the US, noticed that there are some few centers that have actually figure out ways how to engage with these communities, but the problem has not been addressed in all the United States. That's why, for instance, recently we started this program called Roadshow, which is a series of short videos like TEDx-like that enable some of our experts in underrepresented community issues to share best practices. And that's really going back to the conversation we were having before. If we start talking about the problem, that's the best first step. As of today, these problems have been just a matter of conversation in small group, closed door meetings. Now these problems are coming out. And that's, George, what I define part of the revolution. We talk about the problem. It's like the first step. And hopefully the last step of the process is having found solutions that we can all follow.
Can I ask a question? Yeah. Ivana, will there be health economic outcomes in any of these studies?
For iCare AD, yes. So we have had a lot of PROs, et cetera, just how to, in the phase 3, it's always a little bit more challenging to use some of the scales, also because we don't want to create protocols that put too much burden on the patients or the PIs. But in the real world, because the overall protocol is much shorter, we have also added PROs. One of the beauty of iCare AD is that it may offer opportunities to run small sub-studies that can address specific questions. So it's really not just a study, it's also a network of centers. So as we go, we can leverage as a community on that study to address new questions that may come up or more narrow questions.
I think
wondered, one of the things
it's possible, Howard, it seems to me that the Medicare may very well require some sort of evidence development for health economic purposes themselves. So not only do you have 3 studies from Biogen, you possibly have a registry that's the Alzheimer's Association sponsored. We may have one, CED potentially for Medicare. And of course, you're going to have a second and third drug potentially on market where you're going to have both single drug and multiple drug studies for the real world impact of them. So you may end up by the end of next year with 5 or 6 different studies. And the question is, I guess, it's a complex construction question. How do you assure that the data that's being collected is in fact inside a data sharing mechanism where you can compare and contrast different studies? Or we're going to have a cacophony of different outcomes in these different studies at the end of 22 or end of 23. So Ivana, I don't know what the answer to this is, but this is going to be this effort to obtain evidence about the real world benefits and risks of these drugs as a class is going to get very complex in the coming years, very complex.
And while, we cannot predict the future and all the requirements, I think we could commit as a community to try to come together and streamline the process. There is never a benefit in any communities to create a lot of fragmented efforts because, and we have witnessed that in other diseases, a lot of fragmented efforts means burden on the system, burden on our patients. And usually the answers are not always the same because there are a lot of differences the way you design a study, the way you gather data. So I hope that whatever this revolution in the near term brings to us in terms of data generation efforts, we can do that as a community because ultimately we all are looking for the same. We're looking for the right answer for our patients. So hopefully I look at you, George, Nikki, and others, the Alzheimer's Association, we should come to the table and try to find solutions for our community.
That's a great attitude, a great way to end. I'm going to ask each of you just in 30 seconds, 45 seconds, to identify what you think are the most important steps in the next year to 3 years to try to address in order to move this revolution forward. So, Jeffrey, I'll start with you.
George, I think that facilitating the early identification of the patients is so important. We know that doctors tend to make the diagnosis later, and by then they may be out of the treatment window. So I think it's just so important that we put a lot of effort into finding those patients who can benefit.
Howard.
Yeah, I think the commercial rollout of blood tests is going to make a big change in the way doctors care for Alzheimer's patients, and also the cohort of people in the community that'll be eligible for clinical trials. And I also think that as we're seeking approval, this whole issue of healthcare economics, pharmacoeconomics as it relates to these drugs is critically important because there's a lot of people that are going to be eligible for these drugs, and they're not going to be cheap under any circumstances just because they're infusions. So I think demonstrating the health economic benefit of the drugs, the pharmacoeconomic benefit of the drugs is also going to be really important, as well as the traditional outcomes that we measure, such as cognition and function and quality of life, things like that.
Nikki, speak to the patients of the world.
Yeah, speaking for the patients of the world, I think we mustn't forget about low and middle income countries. We talk a lot about these issues, and they're issues for high income countries. But, we know that the numbers of people affected by dementia will increase more rapidly in low and middle income countries over the future. These are often settings without the capacity to diagnose patients. So we do need to be thinking about how we prepare those healthcare systems to be able to create access as well.
And Ivana, last word.
Sure. I think as we have our patients in the ward and not just in clinical trial setting, we need to think how we stay in touch. How do we monitor them on a daily basis? The idea that every 6 months they come to the doctor and they get a visit and we establish how they are doing sounds a little bit obsolete in a world where today with our Fitbit, our Whoop, we track ourselves, how we sleep, how we eat, how we exercise. Why we wouldn't do that with our patients with Alzheimer's disease? So, especially this is for Howard. I think it's time, Howard, we develop something to monitor patients on a daily basis, because the disease is progressing slowly but steadily, and we need to find a way to monitor what's happening. And that may actually change the way we talk to patients, how they are doing. Because today we just have this blunt measure a couple of times a year. But imagine showing someone how the trajectory is going day after day. And at this stage of their life, our patients, every day matters to them. And that's something we need to remember when we think about Alzheimer's disease and their family.
Ivana, that's a perfect ending. I think it also gives us, if in fact we can monitor ourselves, take into account diet, exercise, sleep, and other factors, actually improve our brain health, right? Not just see it decline. So that would be an exciting world. I want to thank you all for joining us today. It was really kind of an active, informed, and intelligent panel. So I am grateful to all of you for showing up, but more importantly, for what you do every day for the patient community. I'm certainly looking forward to see how we all tackle these issues together in the coming months and years. So now to the audience, we're going to take a 15-minute break. And so my clock is saying 9:47, so let's come back at 10. So thank you very much. And we will hear at that time from Dr. Roberta Diaz-Brinton, an impressive panel working on novel therapeutic approaches other than amyloid and tau. So thank you very much for coming today. Panelists, I appreciate your friendship and your work. Bye-bye.